Hello everybody. I am Dr. Ajay Kumar. I am the chairman of Institute of Liver and Digestive Diseases at BLK Hospital, Delhi, and currently the president of Indian Society of Gastroenterology. We are happy to have here Professor Jagannath, who is the world-renowned celebrity, who is the chairman of the surgical oncology at Lilavati Hospital, Mumbai. Dr. Jagannath, good morning to you.
Thank you, Ajay, and it's such a pleasure to talk with you, old friends. So I really look forward to this little chat.
Yeah. It's very nice to meet at the time of the Asia Pacific Digestive Week, where the leaders from the field are present from all across the world. As we look back, Jagannath, say both of us probably started our medical careers at the same age. You went into surgery, I was in medicine. What do you think? I mean, we were in the era when endoscopy was restricted to a diagnostic upper-lower GI endoscopy. Hardly any day-to-day interaction with the surgical team at those times. What do you think, how the things have evolved over years? How do you see them as they have evolved over the last 30 years?
See, you're right. See, when we started, endoscopy was just about in the beginning, and therapeutic endoscopy had just started. And what I see is a tremendous growth of endoscopy and therapeutic endoscopy. In this whole time when we have so many, this conference is a huge success with about 4,000 delegates. What I see is that the interaction between the gastroenterologist and surgeon will start getting more and more closer, and hopefully a kind of a joint effort for the treatment of the patient. So there is a kind of a merger of the roles now, because the endoscopists are doing more surgical procedures and thankfully have replaced some of the conventional surgeries. And at the same time, the surgeons also have to realize what is the expectation from the gastroenterologist, and what they also need to convey what they want from the gastroenterologist. So this is a two-way process, like what we are chatting now together. Every gastroenterologist should have a nice chat or a cup of coffee with their surgical colleague.
So basically, the way you're trying to put forward that it's important to understand for the young people that the surgeon and the endoscopist are not competitors or not adversaries, but are complementary to each other. Am I right?
You're absolutely right. I think our primary focus is the same patient.
Same patient.
And I think in fact, I just finished the talk and said, gave a few examples of what a surgeon would expect an endoscopist to look for in tumors, basically. Like for in gastric NETs, which are very common, what the surgeon wants are the normal stomach or looking normal stomach. The same with the gastric cancer. What are the margins which he is going to get, and not just the tumor. So there is a clear-cut expectation from the surgeon, and if the gastroenterologist gives an appropriate report, it will go a long way in establishing a right kind of a rapport and the best treatment for the patient.
See, this is a very important issue that you raised, that what a surgeon expects from an endoscopic report or from an endoscopist.
Correct.
And I think that's what is very good point to carry, that whenever we write, it's the same way to elaborate your point further. Say like when you have a endoscopic ultrasound done for a pancreatic head massive, for example, so you're basically looking at, correct me if I'm wrong, you're looking at two issues. That what is it operable or non-operable, and is it can give you a preoperative tissue diagnosis or not. Am I right?
Yeah, you're absolutely right, Ajay, that in all the tumors, not just the pancreatic cancer,
Yes.
that what the surgeon is looking for is it resectable or not resectable. He depends on the imaging, and he depends on his gastroenterology colleague. Second thing is, can I get a good tissue diagnosis? In both these, the surgeon and the gastroenterologist have to work together. And you're rightly so that yes, resectability is the first thing which the surgeon wants, and the surgeon wants the margins of the tumor and not the tumor itself. The same thing with pancreatic cancer. Are the vessels free or not free? Is it different or is it the same? And do I need a tissue diagnosis or do not need a tissue diagnosis? So if this kind of an expectations are clearly set before the procedure, then certainly the patient will benefit.
In that context, may I ask you, what do you think are the newer endoscopic technologies which you think have affected the surgical practice?
Yeah, see, there are endoscopic ultrasound is clearly one of them, but we are also now beginning to understand the limitations of endoscopic ultrasound, because endoscopic ultrasound, like
I'm glad that you are raising that issue.
Endoscopic ultrasound, like any other ultrasound, is an operator-dependent technology. So it all depends on how the operator is interpreting an image. And I think it's very important, like in pathology or radiology, that the surgeon has to give a proper feedback to an endoscopic ultrasonologist or even endoscopist, saying that this is what I found on the table, this is what you said is resectable, and I found it to be non-resectable because of these points. This constant interaction is a learning process for both. And the same thing again I would say of EMR, for example. We recently had such a patient that EMR has to be specifically tailored to a certain category of patients and a certain category of expertise which is necessary from the gastroenterologist. If you start doing EMR for patients who are having a little more deeper infiltration, you are bound to perforate the viscous. So this is very important for us to understand the limitations. And for all the younger colleagues who are going into therapeutic endoscopy, advanced therapeutic endoscopy, I would urge you to talk to your surgeon and also make sure that there are limitations which need to be understood for each of these procedures.
I think I'm reminded of Peter Cotton's famous quote that can should not be equal to should.
Totally.
I mean, so we know that an endoscopy, or even for that matter surgery, or for any other field of science, that just because we can do it, that doesn't mean that we should be doing it.
Absolutely right. Absolutely right. I'll tell you a simple example. For hyalocholangiocarcinoma, there is a lot of attempts to made on a cholangioscopy and diagnosis. But if a hyalocholangiocarcinoma is resectable, I don't need a tissue diagnosis. If a head pancreas is resectable on a good imaging, I don't need a tissue diagnosis. So there are some instances where we should not aggressively push a procedure because that may not have any specific need. So the fact that you can do a procedure doesn't mean that you should do a procedure. It's a very, very, Peter Cotton, of course, has profound wisdom, and though he is the pioneer, and that's very important.
Yes.
That wisdom is very important.
Absolutely. Yeah. So knowledge, wisdom, and the capability to do it doesn't mean, and that stands true for both endoscopist and the surgeon.
Totally.
I mean, that's just because we should know the outcomes that what we're going to achieve by that, rather than just because yes, I can cut it, I can remove it, I
totally.
do this.
I think the surgeon has even larger role because he's doing an invasive procedure of a higher magnitude, and he has to understand that just because he can do a procedure, he should not do a procedure. And this is true of like a robotic surgery or any other surgery which is a technology dependent but may not be indicated. So I think this is very important for at least the younger generation. Maybe we are fortunate that we still have that. I think if there's one message we want to give to the younger generation is think before you do, and think carefully before you do.
Well, Jagannath, thank you very much. These are pearls of wisdom which I'm sure that the younger generation, both endoscopists and the surgeons, will benefit from. It has been really a pleasure in talking to you.
Thank you so much for having me here. It's always a pleasure to meet a friend and a great gastroenterologist like you.